Welcome to the Nanovax podcast, a Nanovaccine Institute curated podcast sharing the latest research and advancements in nanovaccines and nanotherapeutics for human and animal health. The Nanovaccine Institute is a consortium of researchers, institutes, national laboratories, and companies founded and coordinated by Iowa State University.
We are developing nanovaccines and nanotherapeutics for respiratory infections, neural disorders, antimicrobial resistance, cancer, aging, and animal health.
Our vision is that nanovaccines and nanotherapeutics will revolutionize how we prevent and treat disease.
Hello, I'm Kathleen Ross.
I am Balaji Narasimhan.
I'm Mike Roof. This season, you will hear from experts across a range of disciplines who study respiratory diseases and antimicrobial resistance.
The first half of the season will focus on respiratory disease and antimicrobial research within the Nanovaccine Institute. The Nanovaccine Institute is pioneering the development of novel, nano-based countermeasures, such as a universal influenza vaccine. We will also talk about other emergent and impactful diseases that have radically changed how we consider and develop policy around global public health.
The second half will focus on the challenges and countermeasures to antimicrobial resistance. Nanovaccine Institute researchers have developed novel nanomedicine therapies to treat chronic disease caused by bacterial pathogens that have developed antimicrobial resistance.
Episodes will explore the different corners of these research topics through presentations on the latest findings as well as conversations among the experts.
Hello everyone and welcome to this episode. I am Balaji Narasimhan, Director, Nanovaccine Institute and Anson Marston Distinguished Professor and Vlasta Klima Balloon Faculty Chair in the Department of Chemical and Biological Engineering at Iowa State University. On today's episode, we will be talking about influenza virus vaccines in neonatal populations, and I have two guests who are experts on this topic. Dr. Jennifer Bermick is an Associate Professor of Pediatrics in Neonatology at the University of Iowa. She runs a basic science laboratory that focuses on understanding how the neonatal immune system develops under normal and inflammatory conditions. This includes the study of fetal and neonatal immune responses during chorioamnionitis and neonatal sepsis, with the goal of identifying therapies that can mitigate the morbidities and mortality associated with these conditions. Also with us today is Dr. Kevin Legge, who is a Pathology Endowed Professor in Pulmonary Immunology Research and Professor of Pathology, Vice Chair for Research for the Department of Pathology, a Professor of Microbiology and Immunology, Director of the Graduate Program in Interdisciplinary Program in Immunology, also at the University of Iowa. He's also an Associate Director of the Nanovaccine Institute, and his lab focuses on dendritic cell and T-cell immunobiology, pulmonary immunity, and vaccines. Welcome, Jennifer, and welcome, Kevin.
Oh, everybody.
So just to get going, maybe can you both tell me a little bit about your academic background and how you came to the University of Iowa? Jennifer, you can go first.
Sure. I was born and raised in the Midwest. I grew up in a small town in Michigan and went to undergrad in Indiana at Purdue University and medical school at The Ohio State University. I went close to home to complete my pediatric residency and neonatal perinatal medicine fellowship at the University of Michigan, and I've been at the University of Iowa's faculty since 2020, which makes this my fourth Big Ten institution. And it was the outstanding clinical care, robust immunology research, and collaborative environment that drew me to the University of Iowa and why I'm hoping to spend the rest of my career here.
Thank you.
Yeah, so I got my start at University of Tennessee as an undergrad in a microbiology lab studying bacteria, and then transitioned as a research technician in the University of Tennessee in an immunology lab, which is where I first really got to the day-to-day operation of immunology at the bench, looking really at dendritic cells and autoimmune disease. I then left the University of Tennessee with my PhD and transitioned to the University of Virginia for my postdoctoral fellowships, with Tom Bracciali, who is well known for studying pulmonary immune responses, and incorporated my interest in dendritic cells into understanding how they were involved in recognizing virus and regulating the immune response. And then I moved to the University of Iowa roughly 20 years ago, almost to the week. And so have been here for 20 years. What drew me here was the really rigorous and strong, vibrant immunology community. As others have told me over the years, there's a lot of people to play with in the sandbox, a lot of really talented investigators that you can bounce ideas off of and really collaborate. And this is a very strong environment for collaboration, which is what drew me here 20 years ago.
Terrific. So just along those lines, for both of you are part of the Nanovaccine Institute as well, which has been there now for 7 years. And I know Kevin and I have been collaborating for longer than that, and very, very happy to start a new collaboration with Jenny, of course. So how do you feel about the collaborative research objectives between the two institutions, and how does it create an environment to pursue the type of research that you are in your laboratories?
Yeah, I think both institutes have a really strong research background. I know in Iowa here, at least, basically 1 in 3 undergrads are in some sort of research during their time here. Very heavily NIH funded with about $683 million in research here at the University of Iowa. And I think both institutions have its strengths. And I think what's really great is the collaborative environment where each of us can bring our own specific expertise to a larger goal. We don't have to relearn everything in every area, but we can work together on that. And I think you see that here with Iowa's strengths in immunology and medical research, both at the basic research and clinical side, with things like the Vaccine and Treatment Evaluation Unit and the CTSA, but also the strong core facilities, working with the Nanovaccine Institute and folks like Microbiology and others there that bring other expertise to this larger picture. And I think that's really both, two Regents institutions at the university in the state of Iowa being able to work together really to move things forward.
I would agree. Even though I'm relatively new to this collaboration, I've been incredibly impressed with the ability to freely share ideas and reagents and everything else back and forth. And I really enjoyed the recent Nanovax conference and how that kind of brought everybody together from both institutions and others to discuss kind of ongoing or potential collaborations.
Great, thank you. So today we're talking about influenza virus, vaccines thereof, and neonatal populations. So for the purposes of discussion here, we're defining neonatal as within 28 days of birth for humans. So many people in the population are caregivers for very young and aged populations, and they may be aware of the challenges and risk that influenza poses to both ends of the age spectrum here. So can you provide an overview of the sort of epidemiology of seasonal influenza for young children, and particularly for the neonate?
So the actual incidence is somewhere around, if you have children under the ages of 1, an incident of about 151 cases per hospitalizations per 100,000 individuals. If you're looking at children ages 1 to 4, the rate is somewhere around 40 individuals per 100,000, about 39. And if you look at children age 5 all the way up through age 49, the rate drops down to around 17 individuals per 100,000.
So it's almost 10 times worse in individuals that are below 1 year of age, and about 5 times as worse for individuals that are between 1 and 4. So pretty significant impact.
Right.
And kind of tagging along with that is the neonatal period, which again is defined as the first month of life, is considered one of the highest risk periods throughout the entire lifespan. And nearly half of deaths that occur in children under the age of 5 occur during the neonatal period, and nearly half of those are from infection. So infection is a really big problem during the neonatal period. Influenza is no exception there. About 10% of seasonal influenza cases occur in children under the age of 5. And as Kevin mentioned, young children have increased rates of influenza-related medical visits and hospitalizations compared to older populations. And children under 6 months have the most severe influenza-related disease and the highest rate of death compared to older children. And unlike many adults with influenza, children who develop severe influenza are typically healthy without any comorbid medical conditions. So it's really difficult to predict who's going to have severe disease.
And I guess the other thing that we can add is, since we're talking about vaccinations as well, is that, for what's actually recommended right now, currently we have two types of vaccines. We have the influenza shot, which is, given in the arms. This is a purified protein-based vaccine. And then we have the live attenuated influenza vaccine that's given intranasally. The LAIV vaccine, which provides some mucosal protection as well as systemic protection, is only recommended for individuals older than 2 to 49 years of age. The flu shot is recommended at 6 months throughout the rest of life. So under 6 months, there is currently not a vaccine that's available.
So given that we're approaching flu vaccine season and people all over the country are getting their flu vaccines, what kind of recommendation is there right now to help protect neonates from these infections, particularly given that there's no vaccine for them?
Yeah, the best way to protect neonates currently is to have those individuals who are around them be vaccinated, including women when they're pregnant, or women of childbearing age. And so pregnant women pass immunoglobulins, particularly IgG, through the placenta in the third trimester. And so individuals who are immunized during pregnancy pass all of those protective antibodies to their offspring, and they stay in circulation for about the first 6 months of life. So immunizing pregnant individuals is probably the best way we currently have to protect neonates.
And I'd add that, surrounding the infant, the neonate, with individuals that are vaccinated just cuts down on the exposure to the virus as well. So not just pregnant individuals, but everyone in the family or surrounding that infant would certainly help cut down on the risk of being exposed to flu.
Right. So, unlike older populations who can cite, malaise or aches or pains, how do young infants, neonatal infants, present clinically with influenza?
Yeah, so children older than 6 months will often present with similar symptoms such as fever, cough, runny nose, and sometimes difficulty breathing. But infants are less likely to present with cough. They're more likely to have fever, runny nose, respiratory distress, and dehydration due to the respiratory distress causing difficulty with feeding. So they may present with some of the same symptoms, but not completely.
Hmm. So how do we, what is our current understanding of neonatal immunity in that sort of first month after birth?
It's poor. So neonatal immunity is vastly understudied and not very well understood. There are many reasons why that is. Neonates are a difficult population to study because they're small. A lot of people don't have access to them, and any neonatal animal models are technically challenging to work with. Historically, the neonatal immune system has been described as immature, and this is usually thought of as decreased immune responses. But recent studies have shown that neonatal immune cells can make robust or even hyperinflammatory responses under certain conditions. So the field has shifted to thinking of neonatal immune responses as immunodeviant or dysregulated rather than immature. Overall, though, what we know is that the neonatal immune system is not able to effectively clear pathogens, bacteria, viruses, and lacks a robust immune memory because neonates don't have the same antigen exposure as older children and adults. And so this combination of lack of immune memory and poor clearance of pathogens contributes to the high risk of infection and infection-related problems seen in the neonatal period.
So that segues nicely into sort of the research that's going on in this field. So you talked about a few of the challenges, Jenny, with respect to understanding neonatal immunity. So what are some examples of basic and translational research in neonatal immunity happening in your lab at the University of Iowa and other places that might help us with respect to building or developing newer vaccines or novel vaccines that are effective?
Yeah, great question. So my lab does both translational and more preclinical basic science models. And the translational piece is actually focused on the preterm infant immune system and development. And so we have a biorepository in my lab where we collect all residual clinical samples from preterm infants from birth until they go home from the NICU. And so we collect serum, whole blood, stool, respiratory secretions, urine, and cerebral spinal fluid from these preterm infants and bank them. And we're trying to first start off by what is normal. So doing longitudinal immune profiling in these infants, and then trying to determine how exposures, early life infections, antibiotic exposure, steroids will contribute to changes in immune development and function over time. And in the preclinical animal models, we primarily use mice. We have models of neonatal sepsis. We have 7 different bacterial sepsis models. We do early life flu and influenza infections, including some studies involving the fantastic influenza nanovaccine that we'll talk about a little bit more. We have models of early life inflammation, chorioamnionitis, which is infection and inflammation of the space around the baby during pregnancy. And so all of these models are really aimed at understanding how the immune system develops in early life and how inflammation alters that.
Oh, that's fascinating. So you also mentioned neonatal sepsis, Jenny. So could you maybe define that for the audience and also talk about the factors that contribute to sepsis-induced morbidity and mortality?
Yeah, so neonatal sepsis, unlike adult and pediatric sepsis, doesn't have one accepted definition by everybody, but we generally think of it as a culture positive infection in a neonate from a site that is considered sterile. So either the blood, urine, or cerebral spinal fluid that is associated with end organ dysfunction, such as kidney failure, low blood pressure, those types of things. And neonatal sepsis is one of the leading causes of death in preterm infants and occurs in up to 29% of preterm infants during their initial NICU stay. It occurs in 0.1% of term infants, but the incidence is much higher in underdeveloped countries. Things that result in more severe sepsis and sepsis-related death include being premature, having sepsis from a gram-negative bacteria, other viral causes of infection, such as herpes simplex virus, also increases mortality, and delayed diagnosis, which is really common because neonates present with nonspecific signs and symptoms when they're infected, such as pauses in their breathing, not looking well, and they kind of present the same way no matter what's going on. And so we often are delayed in our diagnosis. And if we have a delay in starting antibiotics, it leads to higher mortality as well.
So, Kevin, we mentioned earlier that your research focuses on dendritic cell immunobiology. So, can you provide a beginner's understanding of what these dendritic cells are and their role in immunity to viruses like influenza?
Yeah, sure thing. So the easiest way to think about dendritic cells are these are the immune sentinels. These are the folks that stand on the castle and look for the invading, army or whatever's coming. And once they see that there's a problem, in this case, there's a pathogen, in our case today, a flu virus on the way, they run off and tell somebody that there's a problem. And what they tell is they tell the adaptive immune system that, in fact, an infection is showing up in the lungs or in the nasal passages. For the adaptive immune side, they then educate that adaptive immune response to, we've seen a flu virus, or we've seen an RSV virus, or we've seen a bacterial infection, or a parasite, or we've seen a fungal infection, so that the right type of immune response responds to that particular pathogen. Whether that be B cells making antibody, whether that be T cells, particularly CD8 T cells that will target virally infected cells, eliminating them, thereby controlling the viral infection. So these are really the cells that sit really at all barriers, including the lungs and nasal passages, but also the skin and other barriers as well, and really do the surveillance for the immune system, that they look out, see what's happening, and then try to run off and tell somebody about what's going on.
So why is this an important factor, specifically with respect to sort of neonatal populations?
I think for several reasons, and Jenny can probably give more here, but in fact, we know from our own studies in the past, looking at animal models, that some of those dendritic cell populations are different and distinct and may behave differently and distinct than what you might see at older populations. And so if they're not there in number, or the right types are not there, or they can't sense certain pathogens, then you're going to become more susceptible, or you're going to have a deviated type of immune response to what they've seen. So just like most things, they need to go through an education as well, and need to be properly set up to respond to what they're seeing. And in neonate, that's not always optimal.
So, Jenny, this spring you presented at the Nanovax conference, as you mentioned briefly, organized by the Nanovaccine Institute. And you talked about some collaborative work between your lab and Kevin's lab and our lab on nanovaccine to effectively protect neonates against severe influenza in pregnant subjects. So could you perhaps provide a brief summary of the research and your findings?
Yeah, absolutely. So just for some context, the influenza nanovaccine that we used is a polyanhydride nanoparticle provided from the Nanovaccine Institute. And this provides sustained release of antigens through surface erosion and contains both the hemagglutinin and nucleocapsid proteins from an H1N1 influenza strain, A strain, and contains the adjuvant CpG 1668. This nanovaccine has been very effective in adult mouse models. It induces lung resident memory CD4 and CD8 T cells comparable to a native influenza A infection, and induces influenza A specific antibody responses, and protects against lethality in homologous, so H1N1 infections, or heterologous H3N2 influenza A challenges. So we wanted to determine if this nanovaccine was protective in these really high-risk populations that we were talking about, neonates, and during pregnancy, which is also a time of really high influenza-related mortality. So for the pregnancy models, we immunized pregnant mice either before or in early stages of pregnancy, and then infected them kind of in the later trimester of pregnancy, and then followed them over time. And what we found is that the immunized mice had significant survival advantage. 100% survived, while all of the unimmunized mice died from the influenza challenge. And they had significant improvement in their lung function as well. And it didn't matter if we immunized before or during pregnancy, the same response was seen. We also wanted to immunize neonatal mice because, as we talked about, there's no effective influenza vaccine during the neonatal period. And so we immunized mice in the first week of life, which is typically considered the neonatal period, with the nanovaccine, allowed them to grow up to adulthood, and then infected them with influenza A, H1N1. And what we found is that in both males and females, there seemed to be a survival advantage in the influenza Nanovax vaccinated mice. And there's an improvement in lung function and less severe weight loss. And this is really interesting because very few studies have shown a protective effect out to adulthood when you immunize or expose mice during early life. So this is really exciting. We need to do follow-up studies here, but I think that there's some real potential for the influenza nanovaccine to be useful both during pregnancy and during early life.
Yep, that is fascinating, Jenny. And I know we were all very excited after listening to your talk and seeing those very promising results. And I can't wait to see where this leads to as we continue working together. So as we wrap up here, could you maybe both of you summarize sort of what are the long-term goals and outcomes for your research, and particularly in the context of what that could mean for future guidance that is given in a healthcare provider's office and for vaccines on the market?
Yeah, I mean, so I guess let me point out a couple things that are unique about the nanovaccine in general to give you some larger context. So we mentioned the flu shot, we mentioned LAIV, the current two vaccines that are on the market, some of which can be given to populations 6 months and older, some of which can only be given to a narrow pattern between, say, 2 years and 49. They deliver different types of immunity, but they're largely geared at driving an antibody response against one particular protein in the virus. When we actually get infected, we mount a very robust and diverse immune response, including both antibody but also T-cell based immunity. And what happened in 2009 is we understood that, in fact, those individuals that already had T-cells that cross-reacted against the new pandemic strain of flu that appeared either had mild disease or had no disease at all. those whose T cells had existed, pre-existing T cells didn't cross-react against the virus, had a much higher disease burden. So we now understand that really, for at least we think a vaccine that drives both a T cell based immune response as well as an antibody based immune response would probably be the best. And in particular, a vaccine that would drive a mucosal based protection as well as a systemic based protection. The way I always kind of describe this is if you had to protect a particular space, it's much easier to station someone in that space versus calling them in from another city or another state. And you certainly want that type of memory response, but having somebody stationed locally that can fight, but also alert others to come and fight on behalf of the controlling the pathogen would be more optimal. And that's really the goal for the vaccine, is to drive this diverse T cell based immune protection, antibody based immune protection, leaving us with a much larger level of protection versus the virus that's drifting away from our natural antibody based protection every year. So this would be giving us a longer term protection. As you know, we've done this initially in young adult populations, in inbred mice and outbred mice, ferrets, and now non-human primates. The ultimate goal would be to try to get that into a phase 1 clinical trial and bring that to the clinic to bring both the T cell mediated immunity, the B cell mediated immunity, and mucosal based protection. But as we're talking about here today, we have a lot of underserved populations, right, that are not getting a mucosal based protection with the current vaccines and are at the highest risk actually for flu infections. So ultimately the goal for me is, once we get approval in these young adult populations, to be able to transition the vaccine into these underserved populations so that we can provide the most robust type of protection against flu going forward.
Yeah, I would agree. Right now, the only way we have to protect children under 6 months of age from influenza is to try to immunize those around them and recommend good hand hygiene. And we all know from the pandemic how that failed miserably. So I think we need better ways to protect young infants who are at the highest risk against flu. And this influenza nanovaccine has amazing promise from our preclinical studies. So I'm excited to continue the preclinical studies, move to larger animal models with the hopes to move into clinical trials eventually.
And I guess the other thing I would add, Balaji, we've had this from the discussions we've had over the years, that people don't like needles. And this is a needle-free vaccination. And so certainly from talking with my primary care provider who knows what we do, keeps asking when there's going to be another needle-free vaccine on the market, which we would certainly like to be able to do.
No, absolutely. And that's very consistent with the conversations we're having with not just healthcare providers, but also people sort of who are in the trenches, farm techs, nurses who are administering vaccines. The room temperature stability of this vaccine is also something that is mentioned as something that could be a potential game changer going forward. So exciting times. So maybe we'll finish off with the last question here. First, Jenny, and then Kevin. So you both mentioned some long-term goals and some exciting directions in some of the collaborative research that we're all doing. So what do you see as sort of the next steps to make these goals a reality? And also, what are the challenges that still need to be overcome for us to realize those goals?
Well, money is always a barrier, right? So funding. But I have been impressed with all the collaborative, multidisciplinary kind of opportunities between the Nanovaccine Institute and the University of Iowa to try to secure funding for this project and other related projects. So I think that that's something that really positive. And neonates, infants, and pregnant individuals are really high-risk, vulnerable populations to study, especially for human research. And so doing clinical trials on those populations is incredibly difficult. So I see that as being kind of some hurdles and barriers to moving this forward in those populations. But the best way to make that happen is to have really strong preclinical data supporting the safety and efficacy. So I think really working on that should be next steps.
Yeah, I completely agree. I mean, funding for both the basic research side of this, expanding it into additional populations, but also funding for phase 1 and phase 2 and phase 3 types of clinical trials. And Balaji, as you're well aware of, the scale up that will also be necessary to bring this to the market. All of those are hurdles. They're not hurdles that can't be overcome, but they are things that are going to have to be dealt with as we move this further down the line.
Absolutely. Couldn't agree more. And thank you, both of you, Jenny and Kevin, for this very stimulating discussion on a very, very important topic. And hopefully these types of discussions can spur collaborative research that will make vaccines that provide mucosal immunity to these underserved populations. Thank you, everyone, for joining us for this discussion. Other episodes this season will explore other facets of respiratory disease in livestock and humans, and later this season, antimicrobial resistance. Please check out the show notes to learn more about the research discussed in this episode. And please be sure to like and subscribe to the Nanovax podcast in your preferred app or media player.